Hey, everybody. Welcome to the event. It's Mary Coughlin. I am the president and founder of Caring Essentials Collaborative, and today's webinar is about trauma-informed care and the high-risk antepartum. I joined a little bit early, so I'm going to just kind of sit tight and wait for folks to join. Maybe share, your name and where you're calling in from, and we'll get started in just a few minutes. I'm really excited that folks found this topic of interest. Particularly my peeps are from the newborn intensive care unit, right? So I was a little bit worried, when I put this topic out there, but I've just found it really fascinating. I mean, the concept of trauma-informed care in general, fascinating, but the vulnerability of the high-risk antepartum patient has really been speaking to me recently, and I felt, after I, of course, dived in like the nerd that I am, I felt that this information might really help my colleagues really understand a little bit more, with a little bit more insight about what is the backstory, if you will, of the families that we're serving in the newborn intensive care unit. So this is a focus on the high-risk antepartum patient population. Predominantly our mothers. I did find some fascinating information about fathers who have also gone through this high-risk experience. And maybe, depending on the feedback from you guys today, we could make that a subsequent webinar if you feel that's of interest. I know paternal stress and distress in the NICU is certainly a very relevant topic. But of course, we just see these things for the first time in the NICU, and there is a significant backstory to these individuals, to these families, that I think really helps inform us about how we can understand them and how we can best serve them in real meaningful ways. I often say say this expression about the fact that becoming a parent, just like being born, is a defining moment, and how we present ourselves during these defining moments defines us, right? Are we empathic? Are we compassionate? Are we authentic? Or are we just a bunch of technicians focused on doing too? And we don't really want to deal with that messy human stuff, which, trust me, I get it. It's really messy, and it gets messier in crisis, but that's the nature of the work that we do. So I'm hoping that this information will give you a little peek behind the curtain, if you will. And I kind of snatched this subtitle of "When the Bow Breaks" from one of the papers that I was reading, and it forced me to kind of dive in and say, I don't even understand what that means. It's from the lullaby, right? When the bow breaks, the cradle will fall, and down will come cradle, baby, and all. And apparently it has its history in the early American pioneers and Puritans that came over, that they were really intrigued with how the Native Americans rocked their babies to sleep, and they would actually have them swaddled in their little carrier, and they would tie the carrier onto the tree, and the wind would blow and it would rock the baby to sleep. But of course, I don't think that anybody witnessed the bow breaking, but when I started reading that and really kind of putting it to making a parallel to what we do, the bow, right, swinging the baby and embracing the baby and protecting the baby, the bow is the parents, right? And we often see that bow break. We see that bow break on admission over the course of the continuum. And sometimes we don't get to see it in the post-discharge period. So again, I'm going to invite you to come on this journey with me, and let's talk a little bit about what trauma-informed care and high-risk antepartum have in common, and what needs to be kind of reshaped in that space. And so, of course, everyone will get one contact hour for this. You do have to email me if you want the contact hour, okay? And be on my roster. So what I'm hoping at the end of this learning session that you'll be able to list 2 factors that increase maternal risk for psychological distress, and also describe 3 common psychiatric morbidities associated with high-risk antepartum patients. Again, never forget that there's an individual component to this, so these are generalizations, but I think that they can inform us and help us be more cognizant when we're assessing behavior, that we're focused on the question, what happened to you, not what's wrong with you. I think too often we default to what's wrong with you. I mean, we're busy, we're distracted. We need trauma-informed care, right? But we need to really suppress that reflex to say what's wrong with you and really understand what happened to them. I want to just kind of set the stage here with a little bit of an understanding about the neuroanatomy of stress. Again, stress is the body's response to a threat. And, oftentimes, there are good things associated with it, right? I mean, I get a little bit stressed before I do that, these kinds of webinars, when I speak in front of a group. But that stress response actually helps me adapt to my situation, so I can be all jazzed up and have energy and enthusiasm to communicate the information. There's also some negative consequences to stress, particularly when stress is sustained. So the stress system can be activated with not just physical stressors, okay? And I think for NICU people, we're very familiar with some physical stressors, right? There's pain, there's separation, there's cold, there's, procedural touch. There's lots of stressors. I want you to now think about the adult and the high-risk antepartum person, about physical stressors. There's a loss of modesty, right? There's lots of examinations. There's probably some painful procedures as well. It's going to become apparent that I'm not an antepartum nurse, but that's okay. I'm a human being, and I've had some perinatal experiences. But it's also psychological stressors. These psychological stressors can be activated or present themselves to us in a given moment, or they can also be kind of dormant, grounded or buried down from a history of psychological experiences that have been very stressful. So when either one of these or a combination come together, we have a stress response, and we see the key players in the stress response. Again, I know this is a review, but it's the HPA axis and the sympathetic adrenomedullary axis as well, okay? So our sympathetic system, which involves our brainstem, and the adrenal glands, all this other kind of stuff. And so they release a bunch of things, right? Catecholamines, cortisol, inflammatory mediators. And then these mediators, they have specific receptors across the body and in the brain. And they activate, they demand a response. And so, a simple response, physiologic response from the body's perspective would be to run, right, to flee. But in that flee, a lot of other systems kind of get shut down, right? We decrease perfusion to our gut, we decrease perfusion to our skin, and we really put it all into the muscle so that we have the energy to get us the heck out of the dangerous situation. So in an acute event, you can see, yes, this makes perfect sense. But the downside of the stress system is that it's sometimes not able to overcome whatever that demand is. And this happens in situations where the demand is extremely strong, or when we have a state of chronic stress, or coming back to the NICU, but not just NICU, right? And pediatrics in general, all the way up to adolescence. During development, the downside of an overactivated or a chronic stress situation deranges the normal developmental expectations. And some of our high-risk antepartum patients are adolescents. We have to be mindful of that it's easy to just say, because I've done this for a long time, right? Oh, those are L&D patients. I have no idea. I just get the baby, and I just focus on the baby. Now, obviously, there's a benefit to that, right? I want to have a focused focus on my patients. I have an attuned skill set around that. But when I don't really understand the history, the backstory, it really doesn't prepare me to help the family in the crisis that befalls them when they come to the NICU. And the majority, actually, I should have gotten the stats on this. If you're interested, I'll check it out. But a lot of our patients have been identified as high risk patients. Certainly lots of them just come in with an unexpected premature, in unexpected premature labor. But there's a fair number of them that we know that we're expecting. We go to the board, right? That's what we used to do at the Brigham. We go down to L&D and we look at the board and see who's there, who's percolating, how long have they been there. High-risk antepartum isn't like a timeline, right? I mean, you could be have a healthy antepartum course, and then all of a sudden there's an acute event, and you become high risk. And I want you to think about. Oh, I should probably jump to the next slide. Think about that word. Oops, I'm going to go ahead here because what constitutes high risk, and we use that term when we're worried about the outcomes. So in antepartum high risk label is ascribed when we're worried about the outcomes of the infant, the mother, or both. So that's what constitutes high risk. And so that high risk category can be as a result of maternal morbidities, medical conditions, surgical conditions that kind of underpin the pregnancy, and so there's more vigilance in managing the pregnancy. High risk could be because there's multiples. High risk could be because there's some kind of a condition with the fetus alone. Obviously, threatened premature delivery places the patient in a high risk situation. So just understanding it. And again, and this is just me kind of, putting my experiences on it. So you have your own opinions about this, but I feel sometimes because I've been in the ICU for so long, I'm kind of jaded a little bit about what I think is high risk, right? I've seen lots of like insanely bad stuff, like wicked bad stuff. And so other conditions or other circumstances that a normal person would recognize as bad and or high risk, I might be like, no, it's not a big deal. But I need to be more in tune with, it's not about what I think, it's the lived experience of other, and try and control some of that stuff, those perceptions, those judgments, if you will, that come up in the course of our careers, that if you were here for my last webinar when I talked about trauma-informed care for the clinician, can actually be an indicator that I haven't been paying attention to my self-care. So we need to step out of our judgment and look at the lived experience of other. I may not think it's a big deal, but it's not my experience, right? That's all about that individualized care and the defining moments, and how we show up for those defining moments. And so as I talk about, and I know I've gone back and forth, I probably should have ordered these differently, but I just go with the flow as the Spirit moves me to share this information with you. So, we can look at our patient in the NICU's parent, mother, as a high-risk antepartum person. And if we just focus in on that antepartum period, we're really missing their expanded history. What happened to them before they found themselves in this high-risk situation, right? Again, just like everybody who's sitting here watching this video, we have a history. We've adapted to that history, either positively or negatively, right? I mean, there's lots of maladaptive things I know that I do, that are a result of experiences, good, bad, and indifferent, that have helped me kind of figure out how me, Mary Coughlin, is going to walk through the world. Other people might say that is the craziest thing I've ever seen. But that's Mary, right? It's the same thing for our families that we're serving. So looking at the mother, and again, you've heard me talk about this before, but these adverse childhood experiences, which I've introduced to you as a kind of a foundation for this idea of trauma and trauma-informed care for our patients, the adversity that they experience in the NICU. But you don't have to be in the NICU to have early life adversity, to have an adverse childhood experience. And childhood trauma is an event that a child finds overwhelmingly distressing or emotionally painful, often resulting in lasting mental and physical effects. They're 2 times more likely to have depression, 3 times more likely to have anxiety disorders. And when you look at the World Health Organization's report on disability adjusted life years, they call it the DALY report, we're seeing more and more diagnoses associated with depression, but more importantly, anxiety disorders. In fact, the number of anxiety disorders is really outnumbering all the other psychopathologies. Some of these common causes that you see on this slide, look at child abuse, physical, emotional, and sexual. But actually, to be honest with you, the biggest maltreatment, childhood maltreatment, is neglect. It's super underreported, and people endure it. And there are impressions there. It leaves a mark on you. But because it is so pervasive, unfortunately, we tend to not really address it. I'm not saying that it's more important than child abuse. I'm just saying that it's there, it's pervasive, and the numbers are actually thought to be much higher in survivors of neglect, substance misuse, bullying in school, medical trauma, which we talk about the NICU as a medical trauma, but there is certainly psycho-socio and emotional dimensions of the trauma experience for infants and for the pediatric patient population. Long-term impact, again, you've heard me talk about this when I'm focused on the infant, but this is just being a human being, okay? Being a mammal, truth be told. It affects, exposure to childhood trauma affects our perceptions of the world. It affects how we feel either a sense of safety or a sense of danger in the world around us. Our brains are wired differently. We're more vigilant. We're more aware. And for folks that don't have insight and aren't able to retrospect about their own lived experience to really kind of sift through it, a lot of these, you may not really understand why you have these different responses. And so, again, coming to the high-risk antepartum world, where, everything that they have wanted in their life is on a precipice of life and death, right? And particularly for women, I want you to just kind of zoom in on this, is that, having a baby is a big part of being a woman. Obviously not across the board, okay? I'm not trying to make any assumptions about that, but that it is considered one of those, kind of things on your bucket list, and I'm going to have a baby or two, possibly, okay? So when that reality or that dream isn't able to make manifest, that can compound and even re-traumatize that individual based on whatever history they had. The biological areas, I love this graphic because it really helps us connect. This is not these amorphous, feely things. There's actually anatomical locations where the experience of trauma causes derangement in development and perception. So the prefrontal cortex is affected. The amygdala, if you remember me talking about this before, that's your fear center, becomes hyperactive. And they've actually shown some really interesting images of a proliferation of the neuronal network in that area. It's almost as if the amygdala feels like this was a really scary, threatening thing, and I missed it. And so they actually create more neurons to create that hypervigilance, that hyperactivity to make sure, well, we're not going to miss it next time. And you might think, well, gee, that's a good idea, but it actually isn't, because then everything is perceived as a threat. They're actually always on alert. And then, of course, the anterior cingulate cortex, where emotion regulation center, it's in partnership with the insular cortex. And this is where folks, when it is deranged, have difficulty managing their emotions. Now, as I'm saying this, I want you to think about this within the context of the high-risk antepartum person. So the high-risk antepartum person who may have a trauma history, and the majority of people do have a trauma history. I'm just going to call it out, okay? This is the big elephant on the table with regards to our society as human beings, is that there's lots of trauma that young children endure, whether it's neglect, abuse, or medical trauma, mental illness, all that kind of stuff that we don't talk about. And we really need to start talking about this in meaningful ways if we're really going to be agents of healing and be the difference that we want to be, particularly in the work that we do as healthcare professionals. One of the things that I've learned over the work that I've been doing is that emotion regulation, or the ability to regulate your emotions, or the lack of that skill set, is intimately related to your level of mental wellness or mental illness. So the majority of people that suffer from depression, anxiety, schizophrenia, depression, if I didn't say that already, do struggle with a capacity to regulate their emotions. And a lot of that, again, is because of that early life experience of adversity or difficulty that overwhelmed that particular individual. It's not a competition. My trauma isn't any worser or less worse, sorry, than anybody else's, because I experience it through my skill set, my wiring, my genetic blueprint, if you will, which is different from yours. So again, I'm pushing it to you. We have to remove the judgment. It's difficult, right? It sometimes can be challenging to be full on empathetic and compassionate when we're working with individuals, particularly when we're spinning 11 plates and we're feeling pretty overwhelmed. But we need to be present for ourselves and realize, if you're feeling short, if you're feeling abrupt, go take a time out. Go and meditate. Go find your grace, right? Remember that acronym that I shared with you from the wonderful work of Joan Halifax. Gather your attention, recall your intention, attune to the situation, consider what your options are, and then engage in the plan of action that you've created. I generally think of that when you're directed towards your patient, but you could practice grace on yourself, right? Gather your attention, recall your intention, and attune to what's happening inside of you, that the situation is overwhelming. Because these individuals on the next slides I'm going to share with you are profoundly vulnerable and in need of our empathy and in need for our compassion. And so I wanted to share with you, let me see if I've got it over here. How do we determine what is adversity? And I'm sure people even today are doing ongoing research, but this is the questionnaire. This is the questionnaire that was used with the original study with Filiti et al. And his team. And it really hasn't changed since, as people continue to replicate the study to identify the vulnerability of patients based on their early life experience. So the ACE questionnaire, assessing whether or not someone has this adverse childhood experiences as defined by this constellation of categories, when they're looking at abuse, neglect, and household dysfunction. And I put the ACE questionnaire here available to you. It's free online, so I'm not sharing anything out of turn, but I think it's something that you might want to look at. Of course, when I first came across this, I did the questionnaire myself. And I think in the original study I shared that was something like 87% of 17,000 survey participants had at least one ACE. And the ACE, the timeline to evaluate this is you're reflecting on your experience of life from 0 to 18, because that's childhood. And of course, 4 or more ACEs is when the researchers were really starting to see correlations between your early life adversity and your medical morbidities, your medical and psychological morbidities. And so again, we're looking at the antepartum mom who's in a crisis because of her present situation, and you can see that that is very traumatic. It is superimposed onto a history. And so when you look at the 4 R's for trauma-informed care, it's, you recognize that that trauma changes our biology. The last one, and you is about resisting re-traumatization. And so when a high-risk antepartum mom is in that acute situation, that is a trauma to her. It is superimposed on her history. And oftentimes, again, the trauma histories of early childhood, they're not, you don't recall them, all right? But the body remembers. And there's a really great book about that I've got around here. if you're interested in that, if you're interested in anything I'm saying here, please just shoot me a note. I'd be happy to share anything. It's not in my reference list, but it just popped into me. So I want you to, I don't want you to, go up to the high-risk antepartum patient and give them the ACE questionnaire. That's not what I'm talking about. But I'm just trying to get you to kind of understand the complexity. I mean, really, it's the human condition, right? I mean, if you come into the hospital, it's not just your gallbladder, right? It's you're coming into the hospital, and we're greater than the sum of our parts. And we need professionals who are empathic to that, who understand that. And it is a challenge. It's a time challenge. It's a paradigm shift in how we approach these individuals. But I think it's really important for us to be mindful of that. In the preparation for this, I came across this term, which really, I thought, oh my gosh, right? Other folks are examining the experience of people, the experience of these various patient populations beyond the NICU, and using the word trauma. And so what constitutes reproductive trauma is infertility, perinatal losses, and even neonatal losses. This is all considered, well, actually the neonatal losses, I apologize, is not reproductive trauma, but it's considered reproductive trauma. And if you know of anybody who has endured that, unless they're really close and personal to you, you may never know the magnitude of suffering that they are enduring as a result of what they are experiencing. It truly is traumatic and traumatizing. And I can share you, not myself personally, I've not had that, but in my family, I know of folks, and they feel so lost. They feel so isolated. And I think we need to understand that. It needs to inform how we are going to engage with the high-risk antepartum patient. I just came back from doing a really fun 2-day workshop, my surge workshop at a hospital down in Florida. And they created a 2-day event around this workshop. And during one of the sessions, they had a side session where they had some parents come back and talk about their experience. And 2 of the moms on the panel, I think it was a panel of 3, I was with the staff when this was happening, but 2 of the moms talked about that high-risk antepartum consult experience. And so the folks on the call here, if any of you have ever done a consult, so in my role as a nurse practitioner, I have been asked, or assigned to do an antepartum consult. And, you've got your laundry list of things that you need to share with them to prepare them. I mean, it's, we think we're doing the right thing. And I'm not saying we're necessarily doing the wrong thing. It may be the how that could be modified. But these 2 women talked about how devastating it was. And actually one of them shared that she could actually feel like her contractions were coming more frequently. She was becoming increasingly more anxious as the information was unfolding, because her perinatal experience was that she just had to get to 28 weeks. That was her goal. And she was so proud of herself that she had gotten to 28 weeks gestation. And then the high risk, the NEO team comes in and starts basically giving her a laundry list of all of the horrible ththings that were going to happen to her child. May be blind, may not walk, may have significant delays, may die, all these things that we think, well, we're supposed to do this. We're supposed to tell them. And again, I'm not saying that we're not supposed to share information, but it's in the how that we share it. And what was really profound after that experience, I was not present. I was with the clinicians, but one of the NEOs was there, and it really, it shook him. It shook him in a way that really made him feel bad. And again, that wasn't the point, right? But sometimes you have to have that emotional experience to realize we can do this differently. We can do that better. I didn't know. I wasn't thinking. And oftentimes we don't think, because we're just thinking about what we have to get done. And I get it. We got a lot of stuff. We're spinning lots of plates, but we need to step into the experience of other. and understand where they're coming from. What did they need to know in this moment? And how can we share that in a very genuine way? I remember as a learning nurse practitioner, I had brilliant mentors. I feel really blessed. But it was something like, and if anybody, my mentor's listening to me and I mess it up, cut me some slack. But like the diagnosis, right? They would say that your diagnosis, 90% of the diagnosis is in the history. And of course, so for me, it was like, that antepartum history of like rupture of membranes, gestational age, what was the mother's medical history and stuff like that. But I never really dug into what was the psychosocial history of that mom. Did she have a trauma history? How is her capacity to process information? Her emotion regulation, all of that stuff would really help me better communicate with her and engage with her and understand her. And then, when you understand somebody, you can see where their strengths are instead of making assumptions about what they're capable of doing and where they're at, and then getting all frustrated that they're not there. That expression, when you set expectations, expect to be disappointed, because who am I to set expectations on you? When we set expectations or establish them, they need to be established mutually. And the person that you're setting them for needs to weigh in. Is this going to work for you? Because this is, I'm just throwing it out there. So women with a history of reproductive trauma, their trauma is compounded by this. You see the woman here. This silence, this taboo around talking about it, and how we sometimes can minimize it and say, well, it was just a first trimester loss. I mean, you just missed a period. How big of a deal is it? Who are you to make that judgment to a woman who maybe she's been trying to get pregnant for a while, and she's had many losses, and you may not think that it's a viable human being, but it was her baby. And so it's traumatizing. Getting myself worked up here, but it's traumatizing. And so I want to just, help you connect with that sense of humanity, that sense that how we approach these individuals, how we engage during these defining moments impacts them and defines us as either a caring professional or a not so caring professional. Perinatal loss and infertility is associated with depression and anxiety. Symptoms and or can evolve into disorders. These symptoms can have direct or indirect effects on the perpetuation of infertility. And this is a really crappy term, but folks used to refer, when they couldn't figure out a medical etiology for infertility, they would label it psychogenic. It's in your head, right? Psychosomatic, psychogenic infertility. What a horrible term. I mean, but to understand the dynamics of it, because it's important to see, though, that historically we were seeing a connection that having anxiety disorders did confound infertility. And so, again, we really need to dig in and not be so freely labeling individuals, but really digging in and getting that backstory. Beyond what you're currently presenting me with. Instead of just asking me your history about periods and all this other kind of stuff, I really need to get to know you as a human being. And this may be difficult, but what I find is that if you can't share your story, and again, it's not like I'm not telling you when to share your story, right? But I know that sharing your story there's healing in that. And so maybe you can't share your story with me, the nurse practitioner coming in, the neonatal nurse practitioner. Maybe you can't, or maybe you can because you don't feel like you've got a relationship with me. But if you can't, it creates an opportunity for me, if I'm there, if I'm mindful, if I'm tuned in, to recognize that there's something deeper and to make the appropriate referral. That when we can make those referrals, when we feel confident about a screening process that can really better serve this patient to a deeper level, right? It can be scary to like get into the deeper level, into the soul of this person, but That's where all the magic happens. That's where the healing happens. And oftentimes we ignore it because it's messy, or we feel uncomfortable, or I'm not touchy-feely, and all this kinds of stuff. I think it's time. Personally, I think it's past time that we move from, I go into the ICU because I'm an adrenaline junkie and I love all that stuff. And even in high risk OB, right? There's a special person that goes into high risk OB. And I get it. It's challenging. It's, it's stimulating. It's all of that cool stuff. But it's also messy. And these people are in crisis, and that crisis is superimposed onto whatever history they bring. And so when you start observing behaviors, don't be so quick to label it as, oh, they're pregnant, right? So they're crazy. They're very emotional when they're pregnant. There may be something deeper. It's just like when I caution people about labeling the fussy baby. There's something deeper. Nobody's just fussy, but it makes it easy for us. And people buy into this, right? Oh yeah, they're just fussy. Well, what do you do when the fussy baby perfs or blows a pneumo? Maybe the fussy was really that's why babies cry. That's why babies are fussy. They're trying to communicate something to us. And it's our responsibility to investigate it. Mothers, high-risk antepartum women, are already in an acute trauma, and there's a history there. And we need to figure it out. Maybe their emotional state is very concomitant with the trauma and the crisis that they're in right now. Great. But I don't want to make that assumption, because I might be missing something. And when this person presents, when any patient presents to the healthcare community, it's not just about that chief complaint. Although we've got ourselves into that it's just about the chief complaint. We need to be more holistic about what it is that we're doing. Infertility and its treatments are associated with psychological distress. So how are we addressing that? And sometimes people address it by just, oh, here, I'm going to give you a prescription of Prozac. Is that really addressing it? We get so comfortable with symptom management because we're afraid to look behind the curtain. But we need to be careful about that, because then you've got this whole generation now who's hooked on these meds that are dealing with these symptoms, but the root cause is still percolating under there, and it's going to leash out. It's going to jump out. It could jump out in the NICU. It could jump out when they're parenting at home. High risk antepartum. This is a profoundly vulnerable population, and they are such a critical population for our society. Both infertility and perinatal loss, and this is in response to one of the objectives, are associated with significant psychiatric morbidity, and poor outcomes can be prevented. And when I say psychiatric morbidity, that's kind of like that I'm painting, white paint on the paint. Psychiatric morbidity includes suicide. It includes postpartum depression. It includes postpartum psychosis, right? That's, we need to be mindful of this, okay? We're talking about suicide. We're talking about really bad outcomes, psychosis, anxiety disorders. We can prevent this with systematic screening done in conjunction with a system in place to ensure adequate mental health assessment and care. And so, as I start talking about this and asking questions in different facilities, there's a lot of facilities that don't have mental health resources, even though they provide high-risk maternal fetal medicine. And so, and God bless the social workers, right? Because they'll say, oh no, we've got social workers, we're fine. And, I would say, do you have enough social workers? I'd say, okay, you think you're fine? I'd check in with the social workers and find out how fine is fine. And I'm not saying that you're not, all right? I'm just saying that you need to be talking to those point people for them to make the determination if you're fine, if they're fine. Because, in the high-risk antepartum, you can have a significant acute event. It's not just the mom that is high risk now. It is the dyad, the partner, whether they're male or female, that is also in an acute crisis. And people deal with these things in very different ways. And how are we assessing the partner? And how are we supporting the partner? Ideally, you want this to all end as well as it can be, with the ideal goal of being a term healthy birth. But as we well know, high-risk antepartum very often ends up being a high-risk birth. and we end up, moving these people over into the neonatal patient population. Together, high-risk OB and high-risk neonatology, and across the board, we need to come together and figure out what are the systems that we need to really support these people that are in crisis with a history, because we've all got one, with a history that could cause re-traumatization and compromise not only their current chief complaint, the pregnancy, whatever's threatening that situation, but the overall health and wellness of this dyad. So I think, the idea of trauma-informed care is really relevant. And I was like overjoyed when I, was preparing for this, and I came across, there were other references to this idea of trauma-informed birth support. Now, I know that's a bit of a departure from trauma-informed antepartum, but that's kind of the point of this talk. So if we're looking at this, if we have, and this was about doulas, right? That a doula's guide to providing trauma-informed birth support. So again, these are the folks that have figured it out. They've already recognized that there's a history here. I don't want to say ancient history, but a history that predates their childbearing years, that is informing their current situation, that's informing their current crisis, if you will. And even a healthy birth could benefit from a trauma-informed birth support. Because again, regardless of our situation, we have that early life that has informed our bodies, informed our psyche about what the world is all about. And we all look at it differently. We all have different triggers about different situations, different kinds of people, different responses that needs to be factored in how we as healers engage with these individuals during these profoundly vulnerable, private experiences in their life. So this idea of trauma-informed birth really, can set the stage for an understanding of trauma-informed high-risk antepartum care. I have no idea if there's any L&D nurses or high-risk antepartum professionals that are going to listen to this. And this is just the tip of the iceberg. I really wanted to kind of just come out with something to kind of put it out there. Others may have. I've not found anything specific. That doesn't mean anything. But I'd like to keep this dialogue going. And again, turning to you guys as participants in this webinar, how could providing that level of high-risk antepartum care be a nice kind of segue into trauma-informed care in the NICU, that we're all collectively, we're holding hands across the aisle, if you will, or across the floors, wherever your antepartum, high-risk antepartum is, and sharing information that informs us on both sides about where things are at. Because that high-risk antepartum woman, if she has a successful birth, as a live birth, she now becomes a high-risk postpartum person. And maybe if it's not so much physiologic, it's for darn sure psycho-emotional high risk, right? And how do we support these individuals in a meaningful way that honors them with our empathy and our compassion to help them process it? For a while, I've really been focusing on the NICU. And one of the big things that NICU clinicians share with me when we talk about family-centered care, particularly around like educating parents, is, I've been saying the same to them for the past 3 nights. They're just not getting it. I don't know what's wrong with them, blah, 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 whatever. We're all educating them. Well, I get it, but you have to understand people in crisis, they can't hear you. You're telling them lots of complex information and the words are just bouncing off them, and they can't internalize it because they've literally moved from one crisis to another crisis with no acknowledgement of the trauma. And having sympathy isn't an acknowledgement. Sympathy is not what you want to have. Sympathy is pity. You want to have empathy and compassion, not sympathy. I feel really bad for you. Great. What does that do for me? Nothing. But empathy and compassion actually places me as the healer and the clinician in an active place to do something with you, not to you, right? With you. And that's the beginning of being trauma informed, is sitting down with you at eye level and letting you kind of start and guide the conversation. So those high-risk antepartum consultations can take on a whole different meaning, understanding where they're at, not doing them when the patient's alone or unsupported, not telling them everything that can go wrong. Because you know what? You don't know. Yes, they do need to be informed, but not in that one moment. The suffering of that person should not be because I need to check off all these boxes. I can have a human, compassionate, caring conversation with you and pace the information based on creating a therapeutic relationship with you that's going to be create that support of trust and empathy. And also on the other side, the clinicians working in that high-risk antepartum. And I know a lot of you, and you're incredibly compassionate. But I'd invite you to bring that compassion one step further and expand your view of the patient beyond the crisis that presents to you as a result of your clinical competence. And it's messy, and it can make you sad. It can make you mad. It can make you feel all sorts of things. It can make you want to judge. But to try and restrain that and sit down and open up and understand where they're coming from. One of my daughters is a social worker, and I can't get over what she does, because she takes care of homeless people and people that have what they call dual diagnosis, right? So they have a mental health diagnosis, and they also use their substance use. They have substance use, and she loves these people. She meets these people where they're at, and they find joy in her honesty and her compassion, but also her acknowledgement that, they're driving their life car. Her job is to be there, but that they have to share some of their vulnerabilities with her so that she can really serve them in the most meaningful way. And so, when you hear some of the stories of people who have had a trauma childhood and are maybe continuing to have a trauma life beyond their acute trauma situation, to have an authentic healing presence, listen to them, let them share without the worry of judgment. It helps them release a lot of that burden that they have been bringing with them for a long time. It helps them see hope. It helps them feel whole. And it helps them get a glimmer of the wonderful human being that they really are, that we know everyone is, right? And they get to see that through your presence by being and understanding the impact of trauma, both from a historical perspective and in the acute moment. And so, and it also, it's just not, we have to shift from that silo mentality, right? So our high-risk antepartum colleagues can then bridge for us in our efforts to provide trauma-informed care now on this other side of the birth experience, and recognize the history, right, through that shared communication, the history of now the baby is now an extension of the history of that mother and that family. And we know that having an infant in the NICU is a stressful experience for families. Depression symptoms are common and often co-occur with anxiety and trauma-related symptoms, specifically PTSD. And this was a quote that I pulled out of the Roque paper, which is really fascinating. So I've shared a lot of information with you guys. And again, this is new territory for me to kind of walk into. I would love to open up the floor. I'm going to just put the chat thing on, and there's no pressure here, but if you have any questions, I'd love to hear your thoughts about this, your questions about this, any comments that you may have. So I'll try and stop chatting. And of course, you can always ask me questions after you've processed this information. You can see my website here. There's a contact page there, but then my direct email is right below it. I would love for you to reach out and see me, contact me. I'm going to see if maybe I can put my web address here as well. I'm just waiting for you to make a comment. I hope this is not too rude. No questions, no comments. Well, I really hope that you found this interesting. Again, my plan is to really kind of dig even deeper into this topic, explore it with some of my colleagues that work in high-risk antepartum. And maybe what we really could do is work on like a perinatal forum to really talk about this idea of trauma-informed care across that continuum of care, and where each of us as compassionate healers become real stakeholders in bringing this paradigm of trauma-informed care along into this continuum. I think, though, truth be told, my next talk will be really looking about the father's experience and trauma-informed care for the partner, for the parent partner in the antepartum and the NICU experience. So thank you so very much for your attention, for your participation, for giving me this 50 minutes of your day. And please feel free to send me questions. If you're interested in receiving a CNE certificate of this, email me. So get my email address, and I just need to verify your participation, that you're on the enrollment, on the roster for this. And I'm happy to share the certificate with you. So thanks again. And as always, take care and care well, you guys. Bye. Have a great weekend.